Next candidate.
Yes,
Yeah.
yes, doctor.
Yeah. So knee pain, young male, 19 years old, 19.
19 years old.
Yes.
I am presented with a knee radiograph of a skeletal mature patient, 19 years old. I can see permeative lesion seen at the distal part of the femur with very austere action and the Codman triangle, soft tissue swelling, no pathological fracture,
Where do you
no
soft
other
tissue
region.
swelling?
No other.
Where do you see soft tissue swelling here?
Can I take control?
Yeah, yeah, you can take control.
Please, you see my arrow?
Yes, but I don't
I
see it
see this
moving.
one. Uh, Now you can see my arrow.
No, I don't see your arrow moving. I see the arrow, but I am moving it now. Yeah, you move it around. Just try to move it around. Are you able to hear me clearly?
Yes. Doctor, you see me now? You see my arrow
No,
now?
but I don't see your arrow moving. Okay, so yeah, just try it now. I don't know. You're using the trackpad or a mouse.
Mouse.
So just click with your mouse on the screen once and then try to move it.
Like this, okay?
Yeah, I still don't see it. Okay, no problem. Just uh, describe the lesion and tell me what will you do next.
This a lesion is aggressive lesion with wide zone of transition and the Codman triangle. I see soft tissue swelling little below the Codman triangle. So
Okay,
this is aggressive bony lesion. In in 19 years old, I will put osteosarcoma first principal diagnosis. Ewing sarcoma is the differential diagnosis.
okay,
Osteomyelitis also. I will ask about clinical history of the patient and request a MRI for all femur and refer patient to sarcoma center for biopsy and CT cap for staging.
okay. What are you forgetting here? What else you should comment on? If you get the same X-ray in your
Orthogonal view.
exam,
Orthogonal view.
yes. One orthogonal view and other joint involvement that you have not mentioned.
Lateral view will confirm diagnosis of aggressive bony lesion in the distal end of the femur with the wide zone of the transition. I will put principal diagnosis osteosarcoma and request MRI to confirm diagnosis. Other differential Ewing or osteomyelitis.
Do you see any soft tissue swelling here?
I see little above the sclerotic board.
What about this? Do you see my
Soft tissue
mouse
also.
moving?
Yes, yes.
Yeah. So this is the soft tissue swelling. Okay. And in the
Okay,
exam, you should show the examiner with your mouse. So this is the soft tissue swelling. Okay. And there is no
okay,
joint involvement here. Okay.
okay.
Describe it. Go on. Are you able to move
Eh,
or should I move for you?
I will try again. I'm sorry.
No problem. Yeah.
I no.
Yeah. Now I see your mouse moving.
Okay. I am presented with the CT for the same patient. CT confirm aggressive bony lesion at the end of distal end of the femur with the soft tissue component. This one, the soft tissue,
Yes.
cortical destruction. in many parts,
Yes.
and the cortical destruction, and also osseous matrix, osteoid matrix. No other lesion can be identified. No pathological fracture can be seen. The vessel is compressed by the soft tissue component, but I can't see invasion of the invasion of the vessel by the mass, by soft tissue mass. In my daily practice, I want to check other coronal and sagittal view to confirm the. Can I
Okay,
see
what are the
other
what are the
view?
what are the spicules that you see here? What are these spicules?
This one,
Yeah.
osteoid, osteoid matrix
Osteoid matrix or sunburst type of periosteal
and
reaction.
cortical destruction. Cortical destruction also.
This is sunburst type of periosteal reaction. Okay.
Okay,
If you see
okay,
it on bone window, you see it now.
yes.
This one. Yeah. Okay. I'll show you the MRI. I think my internet connection is slow. Sorry for that.
Comment on MRI.
Yeah.
This is okay. This is the MRI coronal cut. Show sorry, infiltrative bony lesion. Confirm the infiltrative bony lesion with soft tissue component at the distal end of the femur with the axial reaction, aggressive reaction and soft tissue component. In my daily practice, I want to see boost contrast to see enhancement of the soft tissue component. No other lesion can be identified. There is cortical destruction and cortical thinning under the soft tissue component and also Codman triangle. This confirm diagnosis of osteosarcoma. I will urgent refer patient to sarcoma center for biopsy. Request CT chest, abdomen, pelvis for staging and bone scan.
Okay, but you did not mention that you would like to see the axial view for involvement of neurovascular bundle, which you were worried about on CT scan.
Yes. I
Okay.
see popliteal artery and vein compressible but not invaded.
Yeah, good. Okay. Why is the T1 important in case of bony tumors?
To confirm cortical destruction
So
and
the
see the
best
cortex well.
best image to see the intramedullary extension of tumor is T1 weighted image. Okay.
Okay,
You can see the exact extent of the lesion. Okay. And suppose
okay.
you have to do a FDG PET CT for distant metastasis. Okay. But you don't have FDG PET CT in your town, but you do have MRI. What will you do?
Sorry, can you repeat again?
Yeah. Suppose you have to do FDG PET CT in an osteosarcoma patient
Okay.
to look for distant metastasis, but you do not have FDG PET in your town, but you do have MRI. So what will you do?
No bone scan also?
You'll do a whole body MRI with diffusion weighted image. Okay. If you do
MRI
not
diffusion?
have, yeah, if you do not have FDG PET in your town, okay, you can do a whole body MRI with diffusion weighted image to look for distant metastasis. Okay.
Okay, okay.
Okay. Good. You did good. But this is a
Thank you.
classic exam case, but you have already also forgotten to mention about the pathological fracture. Okay. It is not there, but you have to mention it. Okay.
Okay.
Next candidate.
Thank you, doctor.
Yeah, thank you. Candidate
Hi.
8 or 9. You're 8, right?
I'm
You're
candidate
7.
7.
Okay,
Yes.
7. Yeah, go on. Shoulder pain.
Okay, I'm presented with frontal shoulder X-ray, the right side. Just have a look in the image. Okay, so the first thing I can see a well-defined calcified structure located at the metaphysis of the humerus. There is no surrounding periosteal reaction or soft tissue component. I cannot appreciate any fractures in the bone, no shoulder dislocation. It shows narrow zone of transition as well. Uh, there is lucent areas inside this dense structure. Um, just having a look on the rest of the bones. So the rest of the bones look more or less like osteopenic. Um, there is no suspicious mass lesion or fractures. So I would like to review the rest of the orthogonal views to have a better look on this lesion,
What do
if
you think this
possible.
lesion could be?
Um, it doesn't look like an aggressive lesion. It could be
Okay,
some
okay.
calcification.
Any other
Okay.
any other lesion on this image? Or any other finding
The
do you see here?
I'm not sure about it, but the rest of the humerus shaft, it looks like there is some decent areas, but I'm not really sure
Besides
about it.
humerus, besides
Besides
humerus,
humerus. Okay. And just have a look on the rest. Mm, mm. No, I'm not really sure. No.
this is the orthogonal view.
Okay. Having a look on the X-ray for the same patient. Okay, so it looks like it's a calcified structure. I can see here that there is surrounding soft tissue lucency around the proximal humerus.
Yes.
Uh, yeah, I can appreciate it in this view better than the other one. So I'm thinking that this could be like a soft tissue lesion surrounding the humerus with this calcified component inside. And
No, this is a bony lesion.
bony lesion, yes, with surrounding soft tissue component. Like it could be like cystic component because it's lucent rather than soft tissue
So do you think
density.
this is a bony lesion with a cystic component? Can you think of something like that? Any diagnosis coming to your mind?
So if we are thinking about a cystic lesion, but this doesn't look like it. Mm,
Forget
Let me
about
just
the
think.
soft tissue lesion. Just focus on this bony lesion and tell me what this looks like.
Okay, so it looks like a well-defined calcified bone lesion. Um, calcified lesion.
You told me that this is a non-aggressive bony lesion.
Yes,
What could be the
yeah.
diagnosis there?
Could be myositis ossificans. Could
We are
be
talking about bone, dear. It is the
okay.
bony lesion. I'm not talking about a soft tissue
Could be
calcification.
could be osteochondroma.
Yes. Now you're talking.
Yeah.
Now prove it. Why is it osteochondroma?
Okay. So I need to review if the patient have any previous imaging and if the patient.
Well, this lesion is arising from the bone. Is it final?
Sorry.
Is it final that the lesion is arising from the bone?
It's overlapping the bone, like
Okay.
yeah.
And it points away from the joint.
Yes, it's away from the joint.
So could it be osteochondroma?
Yes.
Okay, done. One thing is done. This is osteochondroma, right? What is
Okay.
this? Soft tissue
So it,
mass.
yes, this is the osteochondroma, and this is the soft tissue intramuscular myxoma. So this could be like a
Myxoma?
Maser-Broad syndrome.
Mesobrod syndrome?
Yes.
Is Mesobrod seen in osteochondroma?
No, sorry. It's no, sorry.
You're getting confused.
Yes.
Okay, I'll show you the MRI. Okay,
Okay.
and then you tell me. You should have told me something on the X-ray at least, but I'll show you the MRI. Okay, look at this
Okay.
image.
Okay. Can I control?
Yeah, yeah, you can ask for control. Just click on the screen once and then start scrolling. Or you can use your up-down keys also. There you are
Yes, I
looking at
think
all
my
the
hand's working. Yeah.
diagnosis. Just leave it, leave it. You have seen all the diagnosis. I don't know. Hello?
No, I didn't see.
Okay. So just leave your mouse and let me control it.
Sorry.
I'll just show it to you.
Yes.
Okay.
Okay.
Okay. So what do you think about it now? You need just this image to tell me what this is and what this is.
Okay. So now I can confirm that the lesion is arising from the bone.
Yeah.
It looks like an osteochondroma, and this looks like the cartilaginous cap of the osteochondroma.
Mhm.
Uh, so I'm thinking that
Which one is the
this
cartilaginous
looks like
cap? The white one or the black one?
the black one.
No, it's the white one. Okay.
Okay.
Because cartilage has water in it, so it is
Okay.
hyperintense on T2-weighted and star images. Okay, this is a fat sat image. Okay.
Okay.
So what is this soft tissue lesion?
So it could be like a malignant transformation of the osteochondroma.
Malignant transformation of osteochondroma will show the cartilage cap to be thick, like more than 2
Okay.
centimeters, but this is like 2 to 3 mm.
Yes.
It doesn't look like a malignant osteochondroma.
I'm not really sure about this.
Okay, so there could be two pathologies here lying
Okay.
side by side. If this is osteochondroma, what is this?
Could be something related to the synovium.
Take a look at
Not sure.
this.
Okay, it looks like that.
Yes,
So it's intramuscular lipoma.
yes. So there are two pathologies here. One is osteochondroma and other is a lipoma, and both are
Okay.
benign.
Okay.
Okay. And
Okay.
this was the fat set I was showing you to show you that this is fat intensity, completely benign lipoma, and it is called a parosteal lipoma. Okay. And this osteochondroma is also benign because the cartilage cap is too thin. Okay. So this
Okay.
case I brought just to show you that in exam there can be two benign pathologies lying side by side. So don't get confused. Okay.
Okay. Okay.
Okay.
Mm,
Candidate,
okay.
next
Thank you.
candidate, do we have you? Yeah.
Thank you.
Yeah, you're welcome.
Yes.
I think she
Um,
has shown all the diagnosis to everyone, so don't worry. Just whatever. If you have not seen that, that is okay. If you've seen that, that is okay. I'll have my questions. Okay.
oh,
Just describe it and tell me what you see.
okay. Can I have the control?
Yeah. but be careful with the control. Just click on the screen once and then use up and down keys. Yeah, good.
Okay, this is axial cut CT, non-contrast image for the brain. Just I will have a look and then I will comment. Okay. I can appreciate that there is evidence of hyperdensity noted within right middle cerebral artery. Okay. Okay. They appear to be within the right middle cerebral artery, and there is evidence of hypodensity surrounding. Just I wanted to look for the basal ganglia. The basal ganglia appear to be it's still well defined, maybe because of this middle cerebral artery still acute, and there is evidence of hypodensity surrounding, which may be due to edema, and no evidence of hydrocephalus, no evidence of midline shifting, no evidence of hyperdensity noted or hemorrhage noted within the cerebral parenchyma. This could be middle cerebral artery thrombosis with acute infarction in the middle cerebral artery territory, in the right middle cerebral artery territory. This is an emergency. I would refer this patient for the stroke team for management. And also I would proceed for MRI for better evaluation of this extension of the infarction.
Besides this dense MCA sign, do you see any other sign on this scan?
I'm really suspecting also slightly the left one, the left middle cerebral artery, but
No,
it's
that
not
is fine. That is okay.
okay. Just
Any other sign you see besides this dense MCA sign to
any other
suggest that this is early infarction?
okay. Just
Right there.
insular, yes, loss of insular ribbon sign,
Yeah.
and some effacement of the sulci also noted in this
Okay.
region in the vessel.
Okay. In case of hyperacute stroke, okay, you're scanning the CT scan of the patient. You're browsing through it on your desktop, and you're not able to appreciate the hypodensity. Okay.
Hmm.
What will you do then?
I would look for the stroke window.
Yes. What is the stroke window?
As I can remember, I'm not so sure really from the values, but the width would be 120 and the length would be, I'm not sure really. I couldn't remember the number of this.
It's 40-40, okay,
Oh,
or 35-35, whichever you can remember.
40,
Okay.
40.
Yeah. Window
Okay.
level and window width, both 40.
Okay.
Okay. And suppose the patient is still on the table and the stroke team tells you to be very sure that there is thrombosis within the MCA. What will you do?
Apart from this hypertensive sign,
Yeah, apart from this hypertension sign, what will be your next
I
step?
can give contrast.
Yes, you'll do a CT angio. Okay.
Yes. Okay.
Not an MRI. So don't say MRI in the exam, say CT angio first.
Okay.
First you say stroke window. Okay,
Yes.
then you say CT angio if the patient is still on the table.
Okay.
Then if the patient is not on the table, okay, you don't go for MRI directly in case of stroke. Okay,
Okay.
the patient goes to the stroke team. Okay, and what do they do if the patient is still within the window period of 4.5 hours?
They can give thrombolytic agents.
Yeah, they thrombolize it. Okay.
Yes.
And what to do if the patient is out of the window period, like beyond 6 hours?
They can go for thrombectomy, or they should give start with
So
medication.
before deciding for thrombectomy, do they do
I
any
think
investigation?
they should go for MR spectroscope.
Spectroscopy. Interesting. Or something
Perfusion.
else.
Perfusion.
Okay, suppose they don't have MRI with them. What then?
I'm not so sure.
CT perfusion.
Sorry.
CT
Okay.
also has perfusion. Okay.
Okay. Okay.
So they can go for CT perfusion. Okay. So what do they look for in CT perfusion or MRI perfusion?
They would look for the nimbra and they would look for the area of acute infarction. If there is
Yeah.
any area of nimbra, they can go for thrombectomy. If all the area already infarcted and no hope for conversion, they will start. I think they will complete for thrombolysis.
Okay. What is the penumbra to core infarct ratio to decide for mechanical thrombectomy?
I don't know.
Okay. So there should be some mismatch between penumbra and core infarct, right? There should be
Yes,
some
yes,
significant salvageable tissue
yes,
to
but
go
I
for
don't know.
mechanical thrombectomy.
Yeah.
So if the ratio of penumbra to core infarct, if it is more than 1.8,
More
okay,
than 1.8. Okay.
yeah, it is the criteria to go for mechanical thrombectomy.
Okay.
Okay. So otherwise you did good. Okay, we'll move on to the next candidate now. I brought this case just to show you that this is a very common exam case, and you have to go step by step in this case. Okay. And no mistakes will be pardoned in the exam if you make a mistake in a stroke case. Okay. Do we have the next candidate?
Yes, hello.
Yeah, hello. So this is your case. Start describing. What do you see?
Shall I ask for control or just describe this
Yeah,
image?
yeah. No. Ask for control.
Okay. Yeah. Okay, I requested control.
Yeah, given.
Okay. So I'm presented by it's not scrolling, sorry, 1 minute. Sorry, yes, now it started scrolling. So I'm presented with axial cuts of MRI brain, flare images. I can see multiple scatters, areas of hyper intensity seen in both frontal regions and extending to the temporal regions as well. I could also see hyper intensity involving the right occipital region, as well as I think so it's a little jumpy here. I think I also have seen some foci of hyperintensity. Yes, another areas of hyperintensity involving the brain stem, the midbrain, and the pons. So and also a few scattered foci here. Uh, can I see any other sequences available,
Yeah.
like T2?
Which sequence would you
Okay.
like to do? You can go to the
If
T2.
if I can see T2.
Yeah, this is the T2.
Okay. It's not scrolling again. Okay. Sorry, I'm using. So I can see that these areas of hyperintensity are also hyperintense on the T2 weighted images. It's also extending to the cortex. It's extended to the cortex as well. And I'll also check. I'd like also to check the optic nerves on these images.
Good.
So I can see that both optic nerves are slightly swollen, yet I'm not sure of this finding. I would like to confirm it further if any post-contrast images. So at this stage, I'm suspecting this to be a demyelinating disease with this
Good.
distribution. Um,
This is a
so
40-year-old female.
40-year-old female.
Any other sequence you would like
Okay.
to look at?
I like to see the sagittal flare if available.
Sagittal flare. We don't
Yeah,
have
no
sagittal
sagittal
flare, but
flare.
I think
Okay,
sagittal
then
T2.
then the post contrast. Okay, sagittal T2. Okay, I'm trying to scroll. Okay. So I could see like slight thinning of the corpus callosum compared to the patient's age. Um, I would like also to check for the cervical cord on these images for any signal within the cord. So I couldn't see any signal within the cord. So I'm suspecting monocytic disease, yet I don't see like the typical distribution of multiple sclerosis, which is usually distributed upon the callosocapsular interface. I don't see this typical distribution here. So so I'd like also to correlate with the patient immune status. If the patient is immunocompromised, I may think in the line of progressive multifocal leukoencephalopathy, PML, especially that, as I can recall, I saw involvement of the U fibers on the axial images.
Good.
Uh,
This patient has
so
HIV.
HIV. So this makes me again confirms my suspicion of PML because it's more like symmetrical with involving of the U fibers. Other differential could be HIV encephalopathy, yet it usually doesn't involve the cortical U fibers. So I'll convey my findings to the referring clinician and compare with previous images available to see any progression because it's usually a rapidly progressive disease. And that's my statement for this case.
Okay, so the mistake you made
Mm,
here is that you
yes.
first saw the flare, then you
Mm,
asked for T2. Okay,
okay.
flare and T2 are almost similar.
Almost
They
similar.
show almost
Yes.
similar
Yes.
signal. Then
Mm,
you asked, you could have seen something
mm,
here about the corpus callosum, but you then asked for sagittal
okay.
flare or T2. Okay,
Okay.
and you found nothing
Okay.
here. You did not
Okay.
ask for diffusion, you did not ask for SW, you did not ask for
Mm,
contrast.
okay.
Okay,
Mm.
so if you would have asked
So,
for diffusion, you
mm,
would have seen that these lesions are not restricting on diffusion.
not
Okay,
restricting. Okay.
yeah,
Okay.
so that will rule out some differentials. And if you would have
Okay.
asked for contrast, then you would have seen that
Mm,
this is showing incomplete ring enhancement. Okay,
okay.
with open ring towards the
So I
cortex.
think in the beginning
Okay,
I said the post contrast
you
but it
said
was for the
contrast,
optic
but you did not
nerves,
ask for
not
it.
for
Yeah.
yes, not for the optic
And
nerves, not for
the
that
second
for the
mistake you
dramatic
made
lesions.
was that you
Yes.
were making up some findings. Okay,
Mm,
like optic nerves. Optic nerves are normal. You
yes.
said
I've said I'm not sure.
yeah, you later
Yeah.
you told sure you're not sure. Then you
Mm,
said there is some thinning of the corpus callosum. Okay.
yes.
So don't
Mm,
over speak in the exam.
okay.
Sometimes it can land you in the trouble. Otherwise, you
Okay.
made the diagnosis and you
Mm,
will pass this case. But I
okay.
have a
Thank
few questions for you. Okay.
you.
So this patient has a
Mm,
PML infection. Okay. What
yeah.
is the infecting organism here?
I think it's called JC virus.
Okay. So the patient has
Okay.
JC virus infection and the
Mm,
patient is having AIDS. So they start a retroviral therapy of this patient, and suddenly
okay.
these lesions start increasing in size.
Mm.
Okay. And then
So
they
it could
become
be
so,
a form of yes.
yes,
Sorry for
speak up.
interrupting you. Yes, okay.
No, no,
So it
speak up.
could be a form of immune reconstitution syndrome. It's called iris. Yes.
Yes,
Yes.
good. Very
Mm,
good. Very good. Excellent. That's what I wanted to hear.
okay.
Okay. This
Okay.
is
Thank you.
PML with iris. Okay.
Okay. Thank you for
Good.
the feedback. Thank you.
Yeah, yeah, great. Next candidate. Do we have a next candidate? Do we have a next candidate? Mujahid Raza wanted to
Actually,
present.
Dr.
Yes, yes,
Dr.
yes, I can go.
Mariam,
Yes,
right?
I can go. I'm Mujahid. Yes, I can go.
Before
Yes, I
Mujahid,
can.
do we have another candidate?
We ought to have, I think we ought to have Mariam and
Yeah,
Rehanna.
but Mariam went second, I think.
Okay, then Rehanna.
Rihanna, are you
She's
there?
holding 7.
Rihanna, are you there? Okay. So Mujahid, you can go with this case.
Okay.
So this
So this
patient
guy,
is a female of reproductive age group, and whenever she has her periods, she has pain in abdomen.
so first of all, I take the scroll.
Just
I will
increase your
scroll.
voice a little bit. 'Cause
First of all, I will take the request for the remote control.
yeah,
I requested for the remote control.
yeah. Go ahead.
Okay. First of all, I will scroll the whole image, and then I will able to describe my findings.
Yeah.
Here I can see there is a area of altered MR signal is noted in the left adnexal region, which appears to be on T2 weighted images appears to be intermediate in signal. I will want to see on the T1 weighted images.
These are T1 weighted images.
Yes, yes, on the T1 is intermediate signal. I want to see on the T2 weighted images. Can I see on the
Yeah.
T2 weighted images?
Yes.
On the T2 weighted images, it appears to be high signal, and the urinary bladder appears normal. Uterus appears normal. The ovaries appears normal. So the area of altered MR signal which appears the left adnexal region appears intermediate signal on T1 and bright signal on T2 weighted images. Uh, I will also want to see on the diffusion weighted images and post contrast images.
Yes. Go to the see see the diffusion.
Yes. On the diffusion weighted images, this appears reveals restricted diffusion. On ADC also appears high signal. I could not see the post contrast images,
But is
but
there any restricted diffusion or not?
yes, there is restricted diffusion.
So if a lesion is showing high intensity on diffusion weighted images, but high intensity on ADC, then is it true restricted diffusion?
No, it's not true restricted diffusion because it should be low on the ADC images.
Yeah. So you should mention that.
Yeah.
Any other
And
sequence you would like to see?
I want to see this sagittal images, sagittal T2 weighted images.
Check for yourself if you have sagittal T2
Yes,
weighted. Yeah.
sagittal. Yeah, on the sagittal T2 weighted images, here I can see. First of all, I look for the uterus. The uterus appears normal. Uh, there is no evidence of any mass lesion in the uterus. So the main abnormality here I can see is left adnexal region, the cystic lesion which appears high on T2 images. This differential may include endometriotic cyst, or it could be some hemorrhagic cyst. Um,
But do you see any
uh,
signs of hemorrhage?
I could not see any sign of a hemorrhage, but they appears somewhat on the T1 weighted images appears having intermediate signal. So that is suggestive of there is some hemorrhage in it.
Okay. Anything else?
Um, I'm also want to see the any
Okay, the
fat sac
patient
image.
has the history of previous cesarean section.
Yeah, and there is a on the cervical uterine junction, there is mild thickening is noted, and
That is
this thickening
normal.
is okay.
And there is
On the
no high signal on T1 weighted image. So that is not hemorrhage. It is clear fluid, as clear as the bladder.
yes. Now I want to see the axial images again, T2 axial image again. I want to see the scar side. Yes, on the scar side there is some irregularity is noted.
Scar site is normal.
Yes. scar status normal. Mm, this likely represent case of endometriosis, but I could not see where is their deposits are seen. I'm looking
So,
for
and
it.
is endometriosis the only condition where the female can have periodic pain?
Because there is a history of C-section,
Yeah.
and so endometrioma, endometriosis, hemorrhagic cyst, these are the possible causes of the pelvic pain.
So this such a large fluid collection is there. Can it not be the cause of
Yes, this
pain in
could be the cause of.
abdomen?
Yes, this could be the cause of pain. This could be
But this is
hemorrhagic
not
cyst.
hemorrhage. This is
This
not
is endometric,
hemorrhage.
endometric cyst. This could be
This
simple
is not
cyst.
endometriosis. Yeah, this could be a simple cyst. Now
This could
you're
be simple
talking.
cyst.
But is it arising from the ovary?
I can see the ovary. Both ovaries appear normal.
But this is
Uh,
separate from the ovary, right?
yes, this is separate. This is separate from the ovary.
So what
This
else
could be
comes to your
some.
mind?
This could be some collection.
Yeah,
This
what
is
kind of
after.
collection?
This could be due to
Where is the collection
post
coming from?
after the surgery, C-section surgery. There may be some post-op collection.
No. C-section happened 10 years back.
Okay, this could be then there is likely represent in the fallopian tube. Fallopian tube.
No, fallopian tubes are fine.
Okay. This could be some uh, mm, tube-ovarian abscess formation, but ovaries are normal.
I said fallopian tubes are normal. Ovaries are normal, you can
Ovaries are
see.
normal, yes. So could be some dermoid cyst. I will see the fat set images.
Did you
Whether
see any
it's
fat on the
vessel.
T1 weighted image? Did you see any hyperintensity on T1 weighted image?
No, there's no hyperintensity of metal images.
So where is the fat?
So this could be cystadenoma, simple benign cystadenoma.
It is separate from ovary, dear.
Okay. Yes, it is separate from ovary as well as separate from
Okay,
the uterus.
benign or malignant?
This is benign in origin. This is likely benign.
Okay, thank you. Okay, I'll tell you the diagnosis. This is a peritoneal inclusion cyst. Okay. The patient has previous history of cesarean sections. You can see these adhesions, these septations. Okay. So what happens in peritoneal inclusion cyst? How does it form? Okay, because there is adhesions in the pelvis. So whenever the female ovulates every month, some fluid gets collected in the adhesions. Okay. And it forms this peritoneal inclusion cyst. And it is separate from the ovary. And sometimes it is surrounding the ovary. And when it is surrounding the ovary, it is called spider in web sign. So it's like ovary appears like a spider and it's inside this web. Okay. So it's a peritoneal inclusion cyst. This is a benign cyst. So what can they do for the management?
This could be conservative management. If the symptoms could be laparoscopic surgery, surgery.
Conservative treatment like what?
Of this. Just painkiller, just analgesic.
I just told you that the patient, whenever she has periods, so she has pains. Okay. So we have to give her some sort of medication to suppress ovulation. Okay. So we use OCPs to suppress ovulation. Okay. Otherwise, we can go for TVS guided aspiration and sclerotherapy. And in refractory cases, we can go for surgery. But recurrence is very common in these cases. Okay.
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 So this inclusion cyst.
Yeah, this is peritoneal inclusion cyst. Okay. That's why I gave you the history of previous cesarean sections. Okay.
Thanks.
Yeah, thank you. So, any other candidate left? I think we are done for today. We planned for 1 hour. but it's already 1.5 hours, I think. Okay. So I think most of you people are doing really great, and all of you will pass this time. I wish you all the best for your exam. So we'll try to keep 1 or 2 more sessions before your exam, looking at the appropriate time. Okay. So I'll put that in the group, and those who could not attend this, I'll put the recording on the YouTube and you can see the recording. And I hope you like this Viva session. And I tried to keep it just like the real exam. Okay. In exam, you don't know what kind of examiner you'll face. So today I tried to be a little strict with you guys, but don't worry about it. Those who could not perform well, or those who thought that they could not perform well, it's not necessary that in the exam also you'll not perform well. Okay. So all the best to all of you, and just take care of yourself and take care of your health before the exam.